So we are on week 4, 1/3 the way through. First exam is in. Again, you'll have your grades on Saturday. This week you have do a discussion questions and a CJ Sims. If you got one of those assignments with a 0 from this previous week, just resubmit it by Sunday and I'll give you full credit. This is the first and only time I'll do it, but just to show you how it's done and how it's done properly. Another thing you should think about is this is a week where, yes, you do have a quiz coming up next week. For sure you do on this information, but you also have a big assignment coming up on week 8. And in conjunction with community, they're about the same time, same projects. So it's a lot of work, paper, etc. I would highly suggest, number one, pick a pediatric diagnosis that interests you, that you had, your kid had, your uncle had, your next door neighbor, something, or you've seen in a hospital, something that you want to know more about. Is it that your child's kid has autism and you want to know how to treat that child better? Or you have somebody who has diabetes, I want to treat that child better. Whatever the diagnosis is, first of all, send it to me. Let me approve it. I highly suggest you getting a minimum of the paper done this week. It's 250 words. Just tell me what that diagnosis is with some references on it. And you need 2 references on that. I'm trying to help you guys not be on week 8 having to do all of this work and you're overwhelmed. I don't want that for you. I'm trying to show you how to get it done so that you won't be overwhelmed when it gets to the end of this term, because it will be overwhelming. I'm warning you. So let's go ahead, let's do our cahoots, and we'll go from there. Who wants to win a cahoots today? And I know that's you, Xavier. Absolutely, it's going to be you, right? All right. There's like 44 questions here. So I really cover, this topic really well, and as I'm, telling you this topic, one of the things we're going to be talking about is the differences in pediatric and adult care. What are those variations? Why are they different? And if you're not understanding, stop me. I'll try to explain it to you. Say, Xavier was up first, so I guess you do want to win today. Or is it Aaron? Isn't Bobby Fischer a chess player? All right, let's just get going. So week 4, chapters 37, 38, 39. Early detection of a hearing impairment is critical. Which one of these is the primary importance? Like, why do you have to hear? Okay, what I'm trying to explain to you in this question is hearing and speech go hand in hand. If you can't hear yourself speak, you'll be talking like that because you cannot pronunciate. You don't know how to pronunciate. So if you see a child who can't speak or has trouble with speech, what do you need to do first before you institute early intervention like speech therapy? You need to do a hearing test. That's always one thing that you'll start with. Let's start with a hearing test, make sure you hear, and then build upon it.
Yeah, my son suffered from hearing loss, like temporary hearing loss as a kid because of all the ear infections that he got. And
Absolutely.
we had to do speech therapy. He didn't learn how to talk until he was like 3.
Many kids do it, but once you get that speech therapy, they catch on pretty quick. It's quite
Yeah, now he
amazing.
doesn't shut up. He doesn't stop talking now.
So toddlers get the laceration on the arm and they need stitches. Now, kids and bleeding and boo-boos and needles are horrible, right? This kid is not going to be very happy, especially toddlers. So how can we make this easier? Well, number one, putting something there that's going to numb it so they feel touch and not pain. Numbing creams. And we have all sorts of numbing creams out there. To name one, I'd have to name about 10 different types. The other thing is something called Child Life. Now, Child Life came in our hospital, about 2010, I think it was, 29. I mean, a long time ago, but was like all of a sudden they were there in the emergency room. And I'm like, and who are you? And what are you going to do? And why are you in my children's rooms? And what they were doing is on their developmental level, they were teaching them what was going to happen. Because teaching them gives them less stress because they know what's going to happen and they do it on their level. Child Life is an extremely well educated group of individuals, minimum of a bachelor up to a doctorate degree level on how to play with kids on their level, on their growth, their development on their level. So Child Life, get them involved. They are great and they'll help. Let them play and there will be a lot less stress and pain. Recognizes that their toddler has a speech delay compared to their other older siblings. Nursing priority. What do you do? Speech and delay. What's the first thing? Again, you have a speech delay, you got to rule out all possibilities. Is it something to do with the hearing? Again, check the hearing and then go on and institute early intervention, which would be speech therapy. A multi. What are early signs of an early indicator of impaired cognition? So they're not doing what they should be doing, as in, what do infants do first? They lift their head, they turn over, they do a voluntary reflex, voluntary grasping. These are things we look at for growth and development, right? So, what would tell you there's a problem here? Well, when we're talking about fine motor skills, we would say they're not able to grasp by themselves voluntarily at 7 months. Also, they should be able to verbalize by 1 year old. Remember, it's about 3 months old, they're starting to coo and talk to you, right? So by 1 year, they should be saying a one word, whether it's mommy or daddy. That's always, the question. I always say it's Nana first in my household, but there's always one word. Now, another thing is behavior difficulties. Why do you think a child that has impaired cognition would have behavior difficulties? They don't know how to express themselves. They don't know how to tell you what's wrong. And because they're frustrated, they're going to act out in any way that gets your attention. And that could be screaming, yelling, kicking, behavior difficulties. So a child is being treated for a fever. The reason for treating the child's fever is what? Are fevers harmful? Can they be harmful? And that's what this question is trying to talk about. I'll ask you, what do you feel like when you have a fever? You feel miserable, don't you? Achy, painy, oh, not great. Children, when they have a fever, what do they look like? They're sitting in the corner, they're not talking, they're not eating, not drinking, and they're just not playing, and something is wrong, right? We treat the fever because it causes them not feeling well or discomfort. It doesn't prevent life-threatening complications. What you're talking about is seizures, right? So we do have something called febrile seizures that can happen in children from the ages of about 6 months till about 6 years old. Usually they'll grow out of it. And when the fever goes from no fever And quickly, 30 minutes later, you have a fever. So the rate of rise of that fever is so quick that brain says, spark, I don't like it, and goes into a seizure. That's basically what happens to them. Now, is it life threatening? Well, any seizure could be, but the basic reason they've already have a fever. What are you going to treat that fever for? For the discomfort. This child with febrile seizures, you're lucky if you can catch that fever before it goes up because it happens so quickly. And again, we would just be treating that child for a seizure, turn them on their side, keeping their airway open, protect them from injury. Safety, safety. Multi. A child's got something in their eye and it's causing them to be tearing and it's painful. What do you do? There's always an eye question on your HESI, always. I don't know why, but I noticed that from the moment I started teaching in pediatrics at my first HESI. Like, oh, they've got questions about children, something in their eye. This happens a lot, doesn't it? They're always dirt, hair, or something. So what do you do? Well, the book will tell you if it's floating, you take a tissue at the edge and you can grab it out. If something is sticking in the eye, you do not want to do anything, but you want to protect it from going in further, or moving around and causing more irritation. So what we do is we put something called a Fox shield. Now, a Fox shield is a very stiff, rigid eye patch. Usually it's metal, and usually sometimes you put something underneath or something, you leave it open to protect the eye from creating more damage. It's called a Fox shield. The other thing we're going to do is we're going to quickly look at the reaction to the pupil. You can tell the amount of damage to the eye, can't you? Does the pupil still work or not? Again, don't pull it out. Get them to an ophthalmologist or a pediatric ER. All you do is patch it and get them there. Separation anxiety in a child hospitalized. What behaviors indicates the stages of despair? Now, there's something called separation anxiety in children. I mean, we know kids, they don't want to be without mom or dad or grandma at the hospital. And when they're not there, what happens? Three things. They cry, they regress, and then they don't care if you're there, basically in a nutshell. So, separation anxiety, when they first get there, mommy leaves or daddy leaves and they're left alone, they're going to be crying and going crazy. And then they realize nobody's coming. So what happens? They regress. They start sucking their finger, right? Maybe twirling their hair with their finger, regress, be incontinent. These are expected things. That's the second stage of separation anxiety. The third stage is, well, when mommy or daddy finally comes back, the child is like, I'm going to ignore you because you're going to leave again and I don't want to be upset. So they don't pay attention to their mom or dad. That's the third stage. So you should know separation anxiety. A child with a history of abuse, which therapy explores emotional problems. Kids can't express exactly what's gone on because they don't understand it. So with play, they can show you on animals and dolls and stuffed things what has been going on. And it is basically called play therapy, as simple as that. Dramatic therapy would show you if something in the hospital happened. And let's say you didn't like that big CAT scan machine, the kid. Maybe they would sit there and draw a picture of the CAT scan machine. And what about it upset them? These are ways that we can find out what's going on with a kid to make their stays a little bit more comfortable because they're scared to death of us. A multi. When can children react to the stress and anxiety of hospitalization? Now, one of your chapters talks about different sorts of hospitalization, whether it's outpatient, whether it's inpatient, whether it's emergency room, ICU care. Children react to them all differently, don't they? Sometimes we know they're going to go in to get their tonsils removed, right? So we can teach them. But children react before, during, and after. They just really get stressed out by it. If they can't tell you what was going on, that stress might happen again. And children tend to build things up and make them bigger than what they are, right? So know that children at all times. And I prepare the parents, let them know what's going on, you know, in their understanding, that on their growth and development, right? And of course, be aware of it when they go home too. A multi. An adolescent goes to the ER for treatment without parents. How do you get consent for the treatment? This happens more than you realize. I worked the last 10 years in an emergency room, pediatric ER. And many times you'd get that 17, 18, 19-year-old just come into the ER for treatment. How do you take care of them? Now, this is one of your pages right out of your Saunders and Clicks book on informed consents. Important. This is one of those areas that you should really understand. So, can an adolescent go to the ER without parents? Yes. If they're 18 and cognitively aware, they can sign their own consent. If they're not cognitively aware, the parent or guardian must sign for their consent. Well, what if they're not there? Well, you can get a telephone consent for it. Okay. And then the third way that they can come in is if it's an emergency. Let's say they're brought in by trauma helicopter and they're there and you don't have treatment consent. Two physician signatures can validate the consent. You cannot not give treatment because you don't have a parent. If it's an emergency and life threatening, you may deliver care. A child is extremely fearful of hospitalization. What type of play explores these fears? No, that is called dramatic play. Dramatic play just says, I'm going to be the drama and I'm going to tell you what drama happened to me in the hospital that I didn't like, that made me afraid. When checking the IV on an infant, you notice the tissue around the IV is swollen. What do you do first? What's a priority? What's hard about starting IVs on infants is you really don't want to have to stick them again. So you'll do everything to try to make these IVs stay where they are. But if it's swollen or we see some liquid coming around, that IV is not going to be in the vein where it should be. Think about what 10 mLs on you is versus a little infant hand. It could swell up the whole hand. So again, first of all, stop it. Then you're going to look at it, look at the area. If you need to take it out, maybe put a nice warm pack, hospital approved warm pack, and elevate it, and then restart an IV somewhere else. In helping a child to adapt to hospitalization experience, the best approach is what? So you got a kid's gonna have to be in the hospital. They have something going on, they have x-rays, tests, surgeries, all this is planned. Number one is keep them on the same routine. For instance, autistic children, you would make sure the big time of the day is usually mealtime and bath time. So knowing when bath time is a big thing. Do they do it in the morning or do they do it at night? An autistic kid would go crazy if you put it opposite because they're used to a certain routine. So especially autistic, especially toddlers, keep them on the same routine. It keeps them happier. They know what's coming. They know what's coming next. They don't have to worry or be stressed about it. When assessing vision on a child, the healthcare provider would use the Snellen chart At what distance? You've learned this in health assessment. Is there a difference between adults and children? Is there? So it's still 20 feet, doesn't make any difference. And if you're seeing issues with them not being able to see, of course you're going to tell the doctor so that we can make sure, do they need glasses or is it something else going on? Nursing care of discharging a child to home. So you are discharging this child off into their and the parents' care, right? So they need to know what is expected. Are you expecting after a tonsillectomy that that breath is going to smell? Is it going to bleed? What do you expect? That's important, okay? And instructions depends on the age of a child. I know little kids, my 8-year-old grandson, you better give him instructions. He wants to know what's going on. And younger kids too. They can be part of their own care. And you should ask that parents if the child can have those instructions and let the kid have them. Also, something happens that's not what's expected, a phone number, who to call, who to ask these questions to, and then have them repeat the instructions back. So you talk and then they talk it back, and you know that they have the correct information. What is a 3-year-old's biggest stressor of being hospitalized? Just read it your toddler preschool area, right? Toddlers needy. I just gave you this big thing about separation anxiety in toddlers, right? Big thing is parents leaving. Second thing would be not being on the routine. And another thing would be not talking to them on their developmental levels. Those are big things when you talk toddler preschoolers. Multi. What is the best way to alleviate the stress and anxiety of a hospitalized child? Basically what I just said, isn't it? Keep them on their routine, explain the procedures using developmentally appropriate terminology. And then if we can keep parents or grandparents or whoever significant at the bedside, it really does help. What they used to do is do all procedures in the bed of the child, starting an IV, putting down an NG tube, doing a Foley catheter. And then that bed became a place where things could happen. And that child felt very uncomfortable. So, what we found out through research is we have treatment rooms. Bring them in the treatment room. Keep that bed safe. It's their safe place. A nurse notes a string tied around an infant's wrist. An appropriate nursing intervention. I went into my grandson that was just born 3 months ago, and they have one of those tied around his ankle. And I started giggling to myself. And I said, "So, what is that for?" Right? I don't know what it is. What does it represent for you? It could be something religious. I've got this little thing here on my necklace. I don't know if you can see it, but it's a little blue little dot. Sometimes they're black. I got a blue one. But in Miami, the Hispanic population believe that it's an eye to ward off evil thoughts against me. So it's to keep me safe. So they do this on infants, all different religions and cultures and whatever. If you see something you don't understand, ask, because I didn't know what that meant when I moved here from New York, little small town New York. I had no clue. But when I came here, I kept asking questions, and parents do appreciate that you asked. Which urine collection method on an infant is most accurate? The keyword is accurate. And then I'm going to go into 3 types of urine collection with infants and why we would do one of the others. So if you want to have an accurate urine collection on an infant, it would have to be a straight catheterization. And you're like, "Ooh, that's a little bit too much and that must hurt, etc." Well, let's go back and look at an infant. Infants do not have a big immune system. They can't fight off bacteria like older people, right? So we want to take that urine, get an accurate specimen, so we treat it with one antibiotic, and they don't have to keep coming in with repeat urinary tract infections, which could damage the kidneys, right? So we do a urine catheterization when we're looking for an infection, possible a urine infection. If we need to do just a specimen to check a blood sugar or proteins or one of those things, take a cotton ball, put it in the diaper, and you can actually squeeze out that cotton ball through a syringe, and a little drop can go on those little sticks that we use. Those are good there too. Clean catch are for older kids. I've actually seen parents take the child, wipe off their area, and stand them up over the toilet and catch the cup and do it that way, over the sink, sitting on the stretcher. I mean, they've done all the things, but they pee a little bit and grab a little bit. And that could be for older kids. But remember, their immune system is a lot better than infants. So infants, it's going to be a cotton ball to check urine specimen randomly, and catheterization when we're looking for a bacteria that's causing infection. A multi. What is the purpose and function of the family? Family-centered care, right? Pediatrics. Purpose and function of the family. That is where they grow and they live, right? They get all of the emotional support and they have got their safe environment and they grow. Also, the family. That's where we learn about who we are as a person, as a culture, our values. We've got different religions, we have different cultures, and that family is what gives us that. It's not till we go up and out of the family, like about school age, right? Where we start being with more friends and different cultures. Family is so important to pediatrics. The primary goal in caring for the child with cognitive impairment is to what? So you have a child who is not doing all of those growth and development things that they're supposed to do. So what do we do? Well, why do you think we look at fine motor skills, gross motor skills, making sure they're doing what they should be doing? Well, if they're not, we need to make sure that they become the best they can be, as in Nike, right? Be the best you can be, or promote optimal development. Now, how would we do that? In pediatrics, there's 3 different types of things that we would order: physical therapy, speech therapy, occupational therapy. And as soon as we can get that introduced, children are great. Once we introduce and give them that challenge, Children do recuperate very, very quickly. The key is early intervention. As soon as we understand it, get them the proper care, and kids turn around. Just like the little boy now doesn't shut up after learning speech therapy. That's a typical child. Many infants require oxygen. What type is best tolerated and accurately delivered? At birth, a lot of kids get something called TTN, transient tachypnea of the newborn. They just breathe fast. So what they do is they put them on a little bit of oxygen just to ease the effort of breathing, right? So there's all different sort of things. Now, a lot of you chose the nasal cannula. Think about it. Two little prongs sticking up the nose, blowing air, taped to the face so it doesn't come off. That doesn't seem tolerated very well, does it? And a tracheal tube, I don't know if you've ever been intubated, but it is not nice at all. You still feel like you're gagging with it in there. I've had it. Tracheostomy tube, that's sort of uncomfortable. Oxy hood is a clear plastic hood over the infant. You can monitor down to the percentage, 42% oxygen. You can have that in there. And then the kid can look around, suck on his fingers, suck on a pacifier, and be very happy. And that's why an oxy hood is the best. What is the best practice for school-age children with special needs? So they're a little cognitively delayed. They need special needs. Maybe it's speech problems, hearing problems, any problems. What do we do with these children? Are they in a wheelchair, have a hearing aid? Maybe, they can't speak. No speech. I had a girlfriend whose daughter had speech center, had a stroke at birth, they found out. Could not speak. Brilliant, smart child. So what is the best thing? Put them in regular classrooms as much as you can. Just because a child cannot walk, and I'll be telling you all about my Manuel Louis, who was a myelomeningeal who was in a wheelchair. Kid was smart, 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 and he went to regular school. And that's where we should do it. When I was a kid, they had their special classroom. Why? They don't need it because they have something a little extra with them. A multi. Collecting a heel stick specimen on an infant. With infants, we don't have to stick them in their anticube for a blood specimen all the time. The only time we need an anticube is for things like a blood culture or bleeding coagulopathy things. Everything else, CBC, complete blood, electrolytes, blood levels, all can be done with a heel stick. Now, big thing is on the side, we do the heel stick, not in the middle of the heel. That's where the calcaneus bone is, and you could cause osteomyelitis. So on the side, and what you do is you put a hospital-approved heel warmer on. It heats it up. It dilates the blood vessels. It's going to bleed easier. Hold the foot down, not above the heart. Then you use the lancet, and then hold the foot and slowly squeeze it. If you over squeeze it, that heel will get all a bruise. So very slow, little squeeze, and you only need 1.2 mLs for a CBC and complete electrolyte panel. It's not much at all, just very, very easily collected. So hospital approved warmer. Do not put any heated up anything out of a microwave. You'll burn the child. Referrals for cognitive impairment should occur when? So when you think something is going on, you need to get them into early intervention as soon as possible. The quicker we get them in, the quicker they turn around, and catch up to all the other kids. which is what we want. We want the best for these children as quick as we can. Down's children have frequent upper respiratory infections. Why do you think? And you're looking at all the answers and you're saying all of those could be the answer, right? But which one really makes the mucus stick there and can't move and creates dripping and causes that? Is that flat, underdeveloped nasal bone. It's flat. It gets stuck. They can't blow it out and it drips and it causes a coughing and a buildup of mucus. What would be included in the care plan of a patient with moderate cognitive impairment? So when you're looking at cognitive impaired children, again, structure, structure, schedule, schedule. You need to introduce them to all sorts of sights, sounds, touch, even textures. Some children don't like too soft, too hard, too crunchy, different textures in the mouth. Again, safety, 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 safety. Always make sure the toys are safe. And then what are we teaching that child with that skill? Whether it's stacking blocks, whether it's, putting things in order, whatever it is, it should be teaching them something. Autistic children demonstrate which behaviors? I was lucky I was able to do some clinicals for Fortis, and it was at this PPAC that was really amazing. And they had quite a few autistic children, and I actually saw an autistic Downs child, which I think is the most severe of all cognitively delayed, if you think about it. This child would come in and talk about those routines and stuff for these cognitively delayed children. This child knew the routine so well. He'd come in off the bus, take his backpack, put it in his cubby. He'd sit down, wait for his vital signs, and then he would go off to the corner, play by himself, not look at anybody, not talk. And when you call him, they don't even answer by their name. But this was that autistic child. The other thing autistic children do is they do some repeated sort of things. This autistic Downs child would go in the corner and get a chair and take a truck and put it on top of the chair. Then he would take a car, put it on top of the truck. Then he would take a flower and put it on top of the car, and then he'd take the flower off, he'd take the car off, the truck off, and he would repeat, repeat, repeat until you stop them. I mean, that gives them comfort. A multi. Children with autism have better outcomes if. So autistic children, again, routine. Teach them a way to communicate, whether it's orally, whether a picture board, whatever it is. And just because they have autism doesn't mean you're going to accept bad behaviors. You have to correct them when you show it. You did this, you can't do this, you're going to sit there. It's almost like a timeout type thing with autistic children. But just because they're autistic doesn't mean they can be bad. A multi. Fragile X causes. Now, there's two sort of cognitively delayed syndromes we talk about. We have Downs and we have Fragile X. Fragile X is just like Downs, but the other part is they have aggression and usually require medication for it. The other thing is they've got big ears and the facial things that go on. So of course, they're cognitively delayed, so intellectual disabilities, learning difficulties, the aggression, like I said, and then that facial type deformities. So Fragile X is just more severe of Downs with that aggression. What causes autism? We don't really know what causes autism, and I wish we did. It's a little bit of everything. They don't really know. All we know is autism. We usually will not give that diagnosis to a child till they're about 2 years old. Before that, we do not. Um, but you will be seeing some of those cognitively delays, right? Most likely, you might have already put them in some sort of therapies because they're not where they should be yet. But the diagnosis, not till they're 2. Ways children with hearing impairments communicate with others. You put kids in a room that all speak different languages and they can all play, can't they? It's quite amazing. So do they have to speak or hear? No. They do a little bit of all the above, don't they? And it's amazing. They're talking to each other and they don't understand, but they're playing. They know what to do for some reason. What is amblyopia? There's 3 different sort of eye conditions: amblyopia, nystagmus. Amblyopia is what we call a lazy eye. Ever see an eye, one of them just sort of goes off up or down or somewhere? What you do is that eye muscle is weak. So how are you going to make that eye muscle work? You need to exercise it just like you would do your body. So how do you exercise a bad eye? You cover the good eye and make the bad eye work. And that's the treatment. They put eye patches on. And it's whatever the doctor says, 2 times a day, 3 times a day, this many minutes, this many hours, on and off eye patch. And it usually takes care of it. How would you encourage a preschooler to be less apprehensive when taking their vital signs? So again, preschoolers, toddlers, getting them to get anything touched, whether it's vital signs. If we let them sit there and get on their level and we let them talk to us and we let them play with the stuff, taking 2 or 3 minutes will save you 10 minutes chasing them down the hall. Because I've done that too. Kids get really, really fearful, especially toddlers, and then up into the early preschoolers. So again, let them play. Play is always good. What child may be more stressed when they're hospitalized? So remember, we talked about hospitalizations, all different types. We've talked about separation anxiety. Well, what child's going to be more stressed? Something you should know as a nurse if you're working in a pediatric hospital. And you think it's the one who's had all of these different hospitalizations. That's your answer. Think about the child who had sickle cell disease. They've come in. What's the first thing we do for sickle cell disease? We start IV and fluids to dilate those blood vessels, right? It's a needle, first thing. So the child who's the most stressed has had more experience being in a hospital. They've had more chance of bad things happening, right? High functioning kid, no, it's that one who's been in and out so much. And it doesn't depend on the age. A toddler has a hard time fixating on a single point, and the Child's eyes cross the midpoint. It goes and it just can't get to where it wants to make it focusing. We also call it cross-eyed. And the other word is strabismus. Strabismus is cross-eyed. Nystagmus is when they sort of go like seizures and they just shake. Nystagmus. So amblyopia, strabismus, right? Nystagmus. Safety in administering medications to children include, chapter 39, I can't go over all the information in it. It's a lot. I would open the PowerPoint to it. It talks about children administering medicines because they're different than adults, right? In many different ways. It's just not how to give medications. We do milligrams per kilogram, and we always check a name band. Never to ask the child, they'll give you crazy numbers. Also, we used to say, oh, give that to 203B, that room. No, they're not room and bed numbers. We need to call them by their names, okay? And remember, children giving medications, try to give medications to a 3-year-old. How are you going to do it, right? These are the things that you need to, have an idea about. What can help the parents to make a baby swallow their medicines? So you've got a child, a baby, who has it in their mouth, they won't swallow. If you take a big puff of air real quick in their face, they get scared and they swallow. If you squirt it in the back of their mouth, they're going to gag, choke, and vomit on you. If you pinch their cheeks, that's not good enough. They'll still spit it out, and they will. And then if you add it to food or formula, did they eat all the food? Did they drink all the formula? Did they get all the medicines? The best thing is put it in their mouth and blow really quickly. Treatment for amblyopia. How do you treat it? That's the lazy eyeball, right? How do you make a lazy muscle work? We cover the good eye and let that lazy eye work, right? The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What's important? Now, this is a really important topic, especially when you have an adolescent, girl or boy, doesn't matter, that is cognitive impairment. They don't really understand right and wrong, do they? So, what would you suggest a parent or caregiver, do for these children? And it's you need to let them have a well-defined concrete code of sexual conduct, as in good touch, bad touch, and what to do if these things happen. A multi. A child is asking mom about his sibling in the hospital. So how can you alleviate his stress and fear? Today we've got FaceTime. We didn't always have that, did we? But what are other things that we can do? Sometimes we have one child who's always in the hospital, always sick. Could be a cardiac child, could be cystic fibrosis, right? Could be any of those. And sometimes I would sit there and I would have the child in the hospital make them a card. Now, you're having them color, making them a card on how they're feeling. So you're understanding the kid in the hospital, but you're sending something home to the brother or the sister to make them feel, like they're still remembered. And then if they're going to the hospital to see this child, if they're in ICU with a bunch of stuff hanging out, you better have them prepared what they're going to see. Or if they just have an IV in a hand, say that's something that's giving them medicine. Again, letting them be prepared. A multi. What are some best practices when a child is in pain? Pain is always a concept. You're always going to see all age women, men, children, infants, right? This is like global, but we would treat all of them. So the big thing is give the medicine when it's ordered, as it's ordered. We tend to not want to give children their pain medicines because we think it's too much. And we know that at research, we know really good doses. Another thing with kids is distraction. Give them an iPad, turn on cartoons on TV, give them something to play with. That will take their mind off of it, right? And then, of course, repositioning. If they just had abdominal surgery and are laying flat, put their head up. As simple as that. And then perform incentive spirometry after pain medicine. Yes, they need to cough and deep breathe and get up and out of bed and ambulate, but after you've properly medicated for pain, and then they can do it better. Children can be critically ill for long periods of time. So, how do you prevent pressure ulcers? And you're thinking pressure ulcers in children? Yes, they can get really ill and they can get ulcers. A lot of it's nutrition, a lot of it's just plain old nursing care. So, to prevent these pressure ulcers, adult children, very similar, right? So, in adults, you'd be changing a diaper or a chucks, right? Keep them dry. Then use a draw sheet, just like adults, so you don't squirt them up the bed and just sheer injury them. So you pick them up and move them. Also, turning every 2 hours. The other thing I love about children and turning them over, they always have stuffed animals and beanie babies and pretty blankets and all that. I will put them all around the child. I will prop up the ET tube with a beanie baby. I will take blankets and I will roll them up underneath their legs. They'll be hugging a teddy bear. All of that looks good and it's doing what I need it to be. And the parents are looking at the child surrounded by toys. That's what they see, not the baby full of tubes. And last question. Young children can be stressed by being in a hospital. How can you decrease the stress? I think I've repeated this 5 different ways in this cahoots here. So routine, keep the parents and then get good amount of toys, that they like. Again, safety is always thought about. And limiting visitors, well, no, kids want as many as they can if their condition allows it. So let's see how we did today. Huda. 2. Shannon. Good job, Shannon. Number 1. Ton. Good job. And Crystal and Cam. So, okay, remember next week you do have an quiz. It'll be on these informations that you did today. I would also check your PowerPoint for key information that's there about it. Again, your exam grades will be out by 1 o'clock on Saturday. Anybody who wants to get with me and review that exam, let me know, send me a message, and I would love to get with you. If you're rough with math, let me know. I can help you. I've got things I can send you to start with, and then I can tutor you when you're done with that. Any questions? Bye, guys. Always a pleasure.